Yes, ma'am.
Be ready, huh?
Wait for 1 minute. Let everyone comes in the room.
Start.
Yeah, please.
Good evening, everyone. I'm Dr. Anumashita from Madurai Medical College Hospital, Tamil Nadu. So, I'm here to welcome you for the ISA National Online PG class. Today's topic for discussion is Crisis Resource Management. Crisis Resource Management refers to the effective teamwork required in managing the critical scenarios. So, the training in this area will help the anesthesiologist to outgrow his performance and also reduce the mishaps happening during the crisis conditions. So all these things will be dealt in detail in today's discussion. So before we get into the discussion, let's get the blessings of Ma Saraswati. Now, I would request our Honorary Secretary, ISA National, Dr. Sugmita Bajwa sir, to address the audience.
Thank you, Anu. This topic today is a crisis resource-based management. Actually, we have been taught in our PG classes about the anesthesia, OT, the crisis in the OT, how to manage the crisis in the OT, and even to some extent in the ICU. But with the increasing role of the anesthesiology outside the operation theaters in different scenarios, and expanding leadership horizons of anesthesiologists in all fields, especially the emergency medicine and other areas. So you are supposed to be leading the bulk of the teams in all those settings. And invariably in our country, and maybe barring a few setups, you always face these type of resource crunch, whether it's a manpower or it's a equipment or it's a drugs or whatever. To get the optimal use of these things, I think no person better than an anesthesiologist can see these situations and handle the scenarios most efficiently. These things are not taught in the class, not even in your PG curriculum, maximum in the OTs, or you may get a question, short note, or unfortunately a long question also. But these are a very essential part. A PG of anesthesiology should know that, because once they are out from the postgraduate career, they're exposed to the world of the professionalism. And once they are well trained in these type of resource management, you can get accustomed to any situation in the life, any professional life I'm talking about. So today, and we have got all these youngsters, the real youngsters who have been doing this thing in their respective institutes, and they will be presenting this different scenarios and resource-based management in crisis situations. So I would like to hear, and I think that we have got seniors also in this class who will be adding to their experiences and suggestions later on. So I request Dr. Anu and Dr. Pavani to take over from here.
Thank you, sir. I feel pleasure in welcoming our presenters for today. Moderator Dr. Anjali Koshama and other presenters Dr. Krishika Verma, Dr. Kirti Jain and Dr. Priyanka Gupta. So our moderator for today's session is Dr. Anjali Koshama. She is Associate Professor in VMMC in Safdarjung Hospital, New Delhi. She has a PG teaching experience for 15 years. Her specialty interests include simulation, airway, resuscitation. Her achievements are Level 3 certification in simulation, PEDI-STARS, BCLS, CCLS, IRCF instructor, faculty for airway workshops, AMF, co-editor, anesthesiology book under publication by Springer, top 6 in oral presentation in Airway Conference, Chicago, top 10 in poster presentation at Ogby, Ireland. She is an MD and DNB examiner. Her Best Paper Presentation Award 2009 and her publications include 25 cited by 132, H-Index 7, I-10 5. Her book chapters are Eras published in Yearbook of Anesthesiology, Anesthetic Complications, Carcinoma of Larynx and Hypopharynx, Springer Publications. We welcome you, ma'am. The next presenter. Presenter Dr. Priyanka Gupta, ma'am. She is an assistant professor, VMMC and Safdarjung Hospital, New Delhi. She has a PG teaching experience for 4 years and her specialty interests include USD guided regional anesthesia, resuscitation. Achievements are BCLS and CCLS instructor, Indian Diploma of Regional Anesthesiology, and she has presented many papers and posters in national and state conferences. We welcome you, ma'am. Next presenter, Dr. Trishika Verma, ma'am. Assistant Professor in VMMC and Safdarjung Hospital, New Delhi. She has a PG teaching experience for 5 years and her specialty interests include airway, USG guided regional anesthesia and obstetrics. Her achievements are European Diploma in Anesthesiology and Intensive Care (EDR), BCLS and CCLS instructor, Indian Diploma of Regional Anesthesiology and faculty for Airway Management Foundation. She has presented many papers and posters in national and state conferences. Next presenter for our session is Dr. Kirti Jain, ma'am. She is a senior resident in VMMC and Safdarjung Hospital, New Delhi. She has a PG teaching experience for 3 years. Her specialty interests are airway, cardiac anesthesia, simulation and pain, and palliative care. Her achievements include EDR, European Diploma in Anesthesiology and Intensive Care, Certificate Course of Palliative Care, COLS, BCLS, CCLS instructor. She has won Best Paper Award at First National UVACON Conference and she has presented paper and poster at various state and national conferences and has won various quiz and debate competitions. She has few paper publications in PubMed Index Journal and also has a case report published in an international journal. We welcome you, ma'am. Now I would request my screen coordinator, Dr. Pavani Medisetti, to tell about the rules.
Thank you, Dr. Anu. I am Dr. Pavani Medisetti from Tejpur, Assam. Now we will tell the rules. The participants, I would request all the participants to mute off the video and audio during the session, and all the queries should be shared in the chat box, and all the queries will be answered at the end of the session. Now I request our respected mentor, Dr. Anjali Kochar ma'am, and the presenters to take over the stage.
Thank you very much, Pavani, and thank you for the nice introduction. Good evening, respected senior ISA members, colleagues, and dear students. I would like to thank Dr. Sukhminder Bajwa, Honorary Secretary, ISA National, to giving us opportunity to conduct this session. In this session, initially, I will be giving an overview of the anesthesia crisis resource management, and then we will have 3 cases, and we'll have case-based discussion on crisis resource management on the 3 topics. Mostly the topic I have designed towards our postgraduate students. And as sir has already highlighted that in our anesthesiology curriculum, we don't have much of the training focused on the crisis resource management. Though from very beginning in our careers, we are asked to go and manage some or other kind of crisis happening, whether it's OR, in ICU, or in the emergency room. So this talk that I'm going to start, it will focus on the skills and the resources that we might need to use in crisis situation. And as an undergraduate, I think this topic is not very much discussed, and this will also help you if you have any question coming as a short note or in your PG examination. So I begin with the first topic, that is an overview on the anesthesia crisis resource management, and subsequently we'll have presenters who have been introduced in the beginning join us with the case-based discussions. So what is crisis resource management? Crisis resource management is a scientific approach to manage critical events in medical settings. It involves using all the resources available at the personal and team level for the patient in crisis. Although this crisis resource management word, it has come from crew resource management, which was started in aviation industry. And why did they start this program? Because they observed that the most of the airplane incidents that were happening, the mishaps that were happening, they were not happening because their team lacked some skills or some knowledge. They were happening because of the communication gaps between the team members. And they started with these programs of crew resource management. And subsequently, anesthesiology was the first branch to imbibe these from the aviation industry and to start the anesthesia crisis resource management programs. And in healthcare also, the malpractice claims show that it is not the knowledge or the skills of the practitioners, but non-technical skills that might be responsible for 80% of the errors occurring in the healthcare, which can hamper the patient safety. And these non-technical skills are also sometimes called as the human factor or the soft skills that need to be applied in addition to the knowledge and skills that we learn for the best of the patient care. Importance of non-technical skill in anesthesia education was recently highlighted in a paper published in Indian Journal of Anesthesia by Dr. Radhakrishnan. This paper says that both technical as well as the non-technical skills are interdependent, and successful task performance depends on the effective integration of both technical as well as the non-technical skills for any given situation. Now, what are these anesthesia non-technical skills? So main skills that we need in addition to our knowledge and the clinical skills, we need to have situation awareness. We need to be able to do decision making. We need to have an effective teamwork. We need to do proper task management, whether it's crisis or a routine situation. And of course, the communication is the center or the heart of all this. What is situation awareness? Situation awareness is using all the resources that are available, whether it's your manpower, whether it's your equipment, any cognitive aids you have, whatever needs to overcome that crisis situation. And in crisis, the decision making is much more dynamic than what we do in our routine practice. Because the situation is ever changing, we have to quickly decide the treatment plan. We need to quickly distribute the work. We need to decide our team, and we need to communicate to our team what needs to be done. And that is why we need to have some kind of practice, some kind of training, so that these skills can be incorporated with our knowledge and other clinical skills for best patient safety. And task management as a non-technical skill, it has several components. It includes planning and preparation, prioritizing, providing and maintaining standards, and identification and utilization of resources. Now, I will explain you this task managed in the form of a common setting. Every morning, we go to our elective OT. What do? We do a lot of task management. We plan, rather we start our planning of the cases a day prior to the day of OT. Preparation of the cases, preparation of the anesthesia, machine, OR is started on the early morning day before the cases come in, we prioritize the list. We put the high risk on the priority basis as the first case if the patient is diabetic, high risk, and multiple comorbidities. So all this we are doing, whether it's an emergency or routine. Non-technical skills are applicable everywhere. Providing and maintaining standards. We do provide, we stick to monitoring standards. We do practice anesthesia, ASA monitoring standards. We do provide certain standard of pain management, post-operative care to our patients. And task is not complete without our team, without proper utilization of resources, if we want to put a blog, we definitely need our ultrasound machine. So all these resources are useful and one should know where and how they are to be mobilized. And also successful task management requires teamwork. And every team is led by a leader who should have certain qualities to be able to coordinate with our team members, effectively exchange information, to apply some kind of authority as well as assertiveness, which is very much required by a leader so that effective teamwork can be accomplished, but not at the same time maintaining mutual respect, not to cross the line. And assessing capabilities of the team members. If we have to assign roles to our team members, we need to know which person is suitable for which kind of role. To further elaborate on teamwork, a team leader can be any person on the team. Usually it's the senior most member. But if the situation is like that, the resident is already there, he has a better grip of the situation, he has better idea of the patient condition, his comorbidities, any person can be the team leader. ACRM approach encourages all team members can become team leaders, irrespective of the rank. Depends on how well they are in that situation, how well they are placed to manage that crisis. So a team leader needs to give clear roles and responsibilities, and to maintain clear and close loop communication within the team. It is role of the every team member. We learn about the communication also. Team members need to maintain mutual respect. Sharing of knowledge is encouraged. If my team leader is missing on some important point, team members can always add on to as a knowledge sharing and can help the patient in crisis, support each other. And after the management of crisis, it is better that the whole team sits together and does an analysis on what they could do well and what could have been done better. Although the patient might have been saved, although the crisis have been overcome, but still as a team, if we have that small debriefing at the end of the crisis, it can help us learn a lot from each other and to help our system better. Sometimes what is happening is the team is working well, but in the crisis, some system error comes up. Team is working fine, but they could not connect to the blood bank when the patient was bleeding profusely, or some equipment defibrillator was not in working position. It was not working properly. So all these system errors or the equipment problems, sometimes they get precipitated in crisis situations. So one should always look for these opportunities to improve the system as well as the team. Another important aspect of non-technical skill is communication. And I'm sure all of us must have undergone some kind of training in CPR, resuscitation. We do have difficult airway workshops going on here and there for our trainees. And we learn a lot about closed loop communication. In closed loop communication, as we know, is the sender initiates the message and the receiver acknowledges that he has received the message, gives a feedback confirmation, and then sender again verifies with the receiver that the message has been received and the task has been completed. Another communication tool that I want to tell you about is ISBAR communication tool. So any of the PG residents who has heard about this tool can put in the chat box what is the full form of this communication tool. And this communication tool is helpful when we have to take a telephonic consultation, which you might often require in your practice. You are in the emergency duty and you need to consult your consultant on call. and you want to take help from him, take his opinion on the management of the patient who may or may not be stable in the stable condition, or in the ICU, sometimes you need to take the telephonic consultation. These communication tools also come handy when we have to take handover from the patient in the ICUs and in the PACU. You are shifting the patient to PACU, you want to give a quick handover and move on to the next case. So this communication tool can be very useful. So what is this communication tool? The I, it starts with I, introduction, where you introduce yourself, your role, and your location. Identify the patient name, age, give your situation. Why what is the reason for your call? Why it is urgent? Is your patient stable or deteriorating or unstable? What background of the patient? What is his comorbidity? What are his clinical findings? What problem has come up which has led you to make that call? Give that background to the other person. Then assessment and actions. What is your assessment? What actions you've taken till now? What are your probable diagnoses? That can all be communicated in a short manner. And then you can take recommendation from the person whom you have made a call, or you can also recommend to the person who you are giving handover that, yes, this patient might need this referral, or this patient may require certain top up of the medication. So all this can be covered using ISBAR, this communication tool. A message can be delivered in a very concise manner in a short period of time. In a very short call, you can give the whole information without missing on any important aspect of the patient condition. Now this paper that I'm showing, it was published in January this year, and it highlights that this paper is although about the simulation training in anesthesia on crisis resource management. But what this paper also shows is the perioperative crisis scenarios that an anesthesiologist may face. In the preoperative period, may it be compromised airway, hemodynamic instability. In the intraoperative period, it could be machine failure, though it's rare, but we may encounter it any time. And it is such a crisis situation. High spinal, uncontrolled bleeding, and in the post-op, we may have problems with the again, respiratory and cardiovascular system, most common issues. Pain management is another issue in the post-operative period. So an anesthesiologist, beginning from the preoperative to the post-operative period, and also mentioned in the ICU, in the ERs, anesthesiologist is likely to face one crisis situation or another anytime in life. So at that time, what are the key points, crisis resource management key points that one anesthesiology should keep in the mind to overcome that crisis situation? Although there are 15 key points, and I'm going to highlight some of them in more detail than the others. Some of them also involve the non-technical skills that we have just discussed. So first point here is know the environment. This is very, very pertinent. Wherever you're working, whether it's elective or it's emergency or ER, what are your resources? Who all are on your team? What all can be mobilized? Important phone numbers in the emergency, blood bank, radiology, other branches that you may need to communicate to. So know your environment. And we all do. We all check our anesthesia machine when we start our list. So it is very, very important to know the environment. Anticipate and plan. Whenever you are taking up a case, think about what patient comorbidities are there, what kind of surgery patient is undergoing. Is the patient because of the patient condition or because of the kind of surgery? Is he at risk of any sort of complication? Patient coming for posterior facet surgery, sitting position. We keep the possibility of pulmonary embolism, the air embolism in mind. So anticipate and plan. And we put in the center line, we keep the resuscitation equipment ready. So anticipation and planning is very, very important. It also will help you to overcome the crisis. It helps in prevention of crisis situation as well. Call for help early. It is very, very important because it will give you more hands and a fresh mind, fresh perspective into the crisis situation. Establish leadership. Whosoever is in the situation knows the best about the situation can take the role of a leader. Mobilize all the resources that can be done, may it be manpower, may it be the equipment, whatever needs to be mobilized, should be mobilized quick, fast, communicate effectively, use all the available information. Another important aspect is to distribute work. In crisis, sometimes it is all lost. No one knows what exactly is to be done, what is their role in that crisis situation. No one told them to bring the defibrillator when the arrest situation happened. No one asked anyone to load the dose of adrenaline that needs to be injected. So if the leadership, the role of leadership is taken quickly, all this can be managed. A leader can then quickly make the team and communicate them their roles. And the leader will communicate the roles depending on the capabilities of his team members. So for the distribution of work, they recommend that you take a 10-second pause, because for the 10 seconds, you might need to think, what is the problem at hand? What are my people? Who are my people? What work can be assigned? What are the facts of the situation? What is the real crisis here? And you have to quickly make a plan and communicate that plan to your team and then distribute the work. And you can always take feedback from your team and ask the questions. And then the whole team will act to overcome that crisis situation. So this 10 seconds for 10-minute concept, this is can be applied to the crisis resource management. It has been also applied to other industries as well, that whatever the situation is, you always can take out 10 seconds because it will save you another 10 minutes or maybe 100 minutes and so on. Because you have to allocate, you have to mobilize the resources, you have to allocate the work, you have to make your team to overcome that crisis, and definitely 10 seconds can buy you more time for the patient. Another important thing is fixation errors that we must focus on. What are these fixation errors? Sometimes when a problem arises, we just think, oh, it may be, we just keep one diagnosis in mind. Yeah, this is this patient and maybe this is the cause, and we don't make any differential diagnosis. It is sort of a cognitive tunnel vision. Like we're just thinking in a one way. We are not making differential. We are not keeping other possibilities in mind at all. This and only this, that becomes a fixation error. Another possibility is that we do keep a differential, we do make multiple possibilities, but we don't start any treatment. We keep on looking for other cause, keep on looking for something else, everything but this becomes the fixation error. Sometimes we are just relaxed, all is well, everything is all right, situation is under control, not acknowledging that there is a crisis. It can be the biggest fixation error, assuming that everything is all right when it is not. That can become a biggest fixation error. So to elaborate more on fixation error, I'll give you one simple example. I take the example of a young boy who is ASA grade 1 and has come for some fixation of supracondylar fracture of the right arm. So PS is normal, patient is ASA grade 1. You initiate monitoring and you do standard anesthesia induction, secure the airway. And although the baseline vitals were fine, but post-induction, you observe that the BP is on the lower side, saturation is from 100%, it is now 97%. So various situations can be there with various people or various people may think, someone may assume that it is just a post-induction hypotension. I'll just give some fluid and just sits about it. And, next 5 minutes, he's waiting for the blood pressure reading. And then the situation is much worse. He makes no effort to make any differential diagnosis. There is no other intervention done. And the fixation error in this situation could be this and only this, labeling one cause for any situation and not looking for the differential, not working on anything. That can be one error. Other is that making a differential. Could patient be hypovolemic? Could it be sepsis? Is the wound infected? Could it be the drug related? Is it the equipment problem? But not really not giving a fluid challenge, not discussing, not looking for other signs to support the diagnosis. So this kind of error can also be there, which is called everything but this. So just keep on looking for the causes, but not working on any cause. And then all is well kind of situation where we assume that there is no crisis, but actually there might be a bigger crisis. And then we'll end up in trouble. So what will be the right approach to such a case where there is a slight fall in blood pressure post-induction? Every crisis situation, even if it's mild, still there's a BP fall, it is significant, but it is still not a crisis. But prevention of crisis comes a long way. So every situation, it is always the right approach is to assess and manage the situation. Assessment and management go hand in hand in crisis. Make a differential diagnosis. Be aware of the situation. You may recall that the antibiotic was also given at the time of induction, as it usually happens in emergency cases. They are usually not administered 1 hour before, at least in our setup. Make a differential. Is it post-induction? Is it hypovolemia? Could it be drug reaction? Call for help. Start that IV fluid. Take BP readings more frequently. Look whether the patient is responding to that fluid challenge or not. Check your airway and ventilatory parameter. Is everything all right with the ventilation, with the airway? Auscultate chest for any positive findings. And further management based on the findings can be done. So this was an example of the fixation errors. And when we call for help in any crisis situation, we kind of bring in a fresh perspective into the picture, and it can help mitigate fixation errors. Because a team who is working in the stressful situation may not be able to recall all the events, may not be able to have that algorithm or have that thing in mind that this may be the cause. So call for help early is very, very important in crisis situation. Another important aspect is cross-checking of the findings that you have seen. And I don't hesitate to ask my senior resident to auscultate if I am not sure about my auscultatory findings. Sometimes patient is obese and we are not sure about the chest findings. It is always good to cross-check with your other members of the team, and no harm it takes to cross-check your findings. Another important point is to double-check, particularly when you're putting a block, when you are injecting a drug. So one mnemonic is stop before you block. A stop movement before you give any kind of block, to check the surgical site marking and to check the site and side of the block, whether they are same or not. And for prevention of drug errors, we can go for stop, check, and inject. Stop, check the label, check the doses, check the drug name. That are you sure you want to inject this drug at this dosage? And then inject the drug. And drug errors are the topmost cause of the healthcare errors that can compromise patient safety. And a small step of stop, check, and inject can help you overcome such situations. Another key resource management principle is use of cognitive aids. What are these cognitive aids? In crisis situation, as I said, our memory is vulnerable to fail, and it may bring some unforeseen errors. So it is important to have some checklists or algorithms or posters in display wherever it is feasible to display them, or some booklets can be there. We all have, like in our setup, we have a anesthesia machine checklist booklet at the back of the anesthesia machine. In our emergency room, we do have a poster display of the stroke symptoms, acute chest pain symptoms, so that we don't miss on any critical step in the management of the patient. So these cognitive aids help us in not missing any critical step in the management of the patient. And one of the example of the this cognitive aid is the discover ABCD a swift check. This was the algorithm which was developed initially in 1990s when the crisis resource management is teaching in the anesthesia initially started, and they thought that this algorithm can be very helpful when in the anesthesia crisis management when the cause of the crisis is not obvious. And they did a study on the first 2000 incidents in the Australian incident monitoring study, but they realized that this algorithm was able to detect 60% of the incidences, and the 40% then they have to develop another sub-algorithms. But still, as we know, ABCD is the approach that we follow for any peri-arrest situations, and in arrest situation, we go for the CAB algorithm. So these algorithms, they can be very, very helpful in crisis situation. They help us to go through our steps and make sure that we don't miss on any of the critical step. And I will also point out that in this algorithm, as you can see, a swift check of the, not only the patient, of the surgeon, of the process, of the responses. You have to keep check of the overall situation and not only on the one aspect of the situation to overcome the crisis. Now a word about training in CRM before I end my talk. So various methods have been used. Initially, they began with seminar-based trainings. And then now, of course, we know we have many kin-based trainings. We have advanced simulation labs. And it has now become mandatory also for the colleges to have those labs. But you may not require very high-end systems. The training in CRM can be done in a low resource settings with the low resource equipment as well. And many of the non-technical skills like communication, they can be taught using role play or you standardize patient actors who are skilled to depict a particular patient condition. And role play can also be very much useful when you want to instill the qualities of a leadership in your team. And sometimes I also practice this role play. When I go to my theater, I divide my team, and sometimes I ask my second year or first year resident that you are the in charge of theater today, and you are going to tell me what all is to be done. So I give the person opportunity to become the team leader. And of course, we facilitate them to learn the role of leader, and we can all practice these small things for the training of the non-technical skills in our anesthesiology curriculum. So to summarize, I will say that although adapted from a aviation industry, ACRM can enhance patient safety in healthcare. When combined with knowledge and skill, non-technical skills can help in managing crisis situation better. Key principles of crisis resource management can be applied to routine as well as emergency situations. And simulation is just one of the modality to learn and practice ACRM. We can always have our residents practice our non-technical skills in our routine practice as well. Thank you very much. And now I will like to invite our next speaker for the day. So the first case that we are going to discuss is about a patient. So I will like to invite Dr. Kirti Jain for the next presentation, and she will introduce her topic to the house. Dr. Kirti Jain.
Good evening, respected seniors. So after having a background information of what is anesthesia crisis resource management, let's switch on to case-based discussion on perioperative anaphylaxis. These are my learning objective for today. I'll start my lecture with the case scenario. A 25-year-old female weighing 50 kg diagnosed with subacute intestinal obstruction was planned to undergo emergency exploratory laparotomy under general anesthesia. Her past history is non-significant. Medical history, she do not have any chronic medical condition. She gives a history of allergy to penicillin, no other known food allergy. Her preoperative investigation and airway examination are fairly within normal limits. Vitally, she is stable. Her NPO status is adequate. No pre-medication was given. So patient arrived in the OR. Anesthesia was induced using injection fentanyl, 100 mics IV, injection propofol, 100 mg IV, and rapid sequence induction done using rocuronium, 60 mg. Now, in few minutes, we noticed that the saturation started falling to 85%. Immediately, intubation was done, but we faced difficulty in ventilating the patient. The airway pressure increased to 34 centimeter of water. At the same time, the BP started falling to 68 by 32 millimeter of mercury. The heart rate raised to 120 beats per minute. We gave mephentermin 6 mg IV bolus, but the BP did not rise. We repeated the bolus dose, rushed the fluid, phenylephrine was given, but the BP still did not rise and it fell down further to 50 by 28 mm of Hg. At this time, we noticed conjunctival edema in the patient's eye. So now what to do next? In this context, we'll begin the talk. We as anesthesiologists face various situations to manage patient in ICUs, under operation theater, in radiological suites, emergencies, trauma. Here we end up giving multiple drugs, blood products, the contrast agent. All these can result in major adverse reaction or immediate hypersensitive reaction. One of the life-threatening form of this immediate hypersensitive reaction is anaphylaxis, which occurs due to massive release of multiple physiologically active mediators by the inflammatory cells. So the anaphylaxis happening under this scenarios are called perioperative anaphylaxis. The incidence of perioperative anaphylaxis is often underestimated. It varies between 1 in 3,500 to 1 in 20,000 and is more common in female when compared to male. The mortality is roughly between 1.5 to 7%. 5 to 7% of all death occurring during anesthesia is attributed to perioperative anaphylaxis, and among 2% of the individual who survive end up with hypoxic brain injury. So what are the pathophysiology of anaphylaxis? IgE-dependent allergic mechanism is recorded only in 60 to 70% of the individual. Hence, there are other postulated mechanisms which also cause anaphylaxis. They are non-IgE dependent. It could be via immunoglobulin G or complement mediated. The other non-allergic mechanisms are direct mast cell activation, as we see in drug like atracurium, cisatracurium, morphine, which cause release of histamine. There could be dysfunction of arachidonic acid metabolism. So, to sum up, the mechanism of anaphylaxis can be IgE mediated, non-immunoglobulin E mediated, or via direct mast cell and basophil cell activation. For IgE mediated reaction, it requires prior exposure. The substance to which an allergy has happened is called an antigen. Antigen can be a protein or a drug. So this antigen or the protein is processed by the antigen presenting cell presented via the major histocompatibility complex, which causes recruitment of the B cells. The B cell now generate immunoglobulin E. This immunoglobulin E binds to the high affinity receptors located on the mast cells. So once this complex is formed, when there is re-exposure of the same agent, it causes huge release of vesicle material from this mast cell and the basophil cell into the systemic circulation, which is responsible for all the manifestation. So IgE mediated reaction usually occurs when there is prior exposure. It is in more severe form. It is amenable to desensitization. Pre-medication with steroids and antihistaminics are not much useful in IgE mediated reaction. Example of such reactions are a patient giving history of food allergy, insect sting injury, insect sting allergy. The non-IgE mediated reactions do not require prior exposure. Here the pre-medication might be useful. These are seen in patients receiving dextrins, drugs like aprotinin. And the third mechanism is direct mast cell and basophil cell activation. Here again, the prior exposure is not required. It is rate dependent. It depends on how fast we give the drug. So we always advise to give the drug at a slower rate. Here the pre-medication might be helpful. So the drug which cause histamine release are example like atracurium, cisatracurium, morphine, NSAID is the vancomycin-causing red man syndrome or example of direct mast cell and basophil cell activation. So once we know the pathophysiology, what are the etiology for anaphylaxis? Before knowing the etiology, there are certain risk factors for perioperative anaphylaxis. They are a patient who had a prior history of any periprocedural reaction, allergy to any drug, food, or fruit allergy. The famous fruits are avocado, pineapple, kiwi, and papayas. A person who has undergone multiple past surgeries, more than 5 number, history of atopy, they're more prone for allergy to latex and radiocontrast medium, mast cell disorders like systemic mastocytosis, and a patient with hereditary angioedema. These are high-risk patients for perioperative anaphylaxis. Now, what are the triggers for anaphylaxis? It can be remembered by the mnemonic ABC. A stands for antibiotics, and among the antibiotics, the most common one is penicillin and cephalosporin. That is why we always give test dose before giving any antibiotic. And for the blocking agent, both polarizing and depolarizing are causing allergies. Among the polarizing, the most common one is rocuronium, and then atracurium and cisatracurium. Among the depolarizing agent is succinylmethonium. Chlorhexidine, which is used for skin asepsis, is also responsible for causing perioperative anaphylaxis. And finally, latex. In Europe, there were a number of case reports which said the majority of the perioperative anaphylaxis in their setting was occurring due to neuromuscular blocking agent. When they were using foclodine for cough suppressant, this foclodine has a quaternary ammonium compound. So this is an antigen, which is also present in our neuromuscular blocking agent. So the cross reaction of that quaternary ammonium compound is seen with neuromuscular blocking agent. Hence, they reported higher incidence of perioperative anaphylaxis with the neuromuscular blocking agent. But ever since foclodine was stopped, the anaphylaxis reaction attributing to the neuromuscular blocking agent have reduced in European nations. So the question number 1, which neuromuscular blocking drug is associated with highest incidence of allergic reaction? Can you please answer in the chat box? We can discuss the answer later. Can I switch? So now once we know what is
No, I think,
anaphylaxis.
excuse me, Dr. Kirti, I think you can just finish off with the answering now,
Okay, ma'am.
depending on the questions, answers which have come in the chat. I think maximum people have given the choice as A, atracurium.
Yes, but
And
the
only one-
answer for this is D, rocuronium.
So you can just explain, can you explain why rocuronium or
See, the mouthwash we use and various other chemicals have ammonium compounds. Rocuronium also have a quaternary ammonium compound. So there has been cross reaction, cross sensitivity of those agents with this, and this is responsible for causing anaphylaxis.
yes.
So once we know what is anaphylaxis, what are the risk factors, what are the trigger factor which causes anaphylaxis, now let's move on how to diagnose it. Always remember, anaphylaxis is a clinical diagnosis because the laboratory tests are not immediately available. They're cumbersome, costly, and they do not give an instant result. Any patient with anaphylaxis present with acute onset of generalized mucocutaneous sign with or without respiratory compromise and cardiovascular instability. Under perioperative setting, any patient who has unexplained hypotension refractory to vasopressors or unexplained difficulty in ventilation and bronchospasm should arise a suspect for anaphylaxis. Why don't we have a mucocutaneous sign here? Because most of the time our patients are covered by drapes, so it may not be visibly evident. And also this cutaneous sign become more evident only when the perfusion is restored. In a patient with hypotension where perfusion is deranged, these signs may not be evident and they may tend to occur after some time when the perfusion is restored. As I said, for diagnosis, we mainly rely on the clinical aspect. because the lab tests are cumbersome, they are costly, and they're not immediately available. One of the agent which is required to diagnose anaphylaxis is serum tryptase. As I said, when when the immunoglobulin E attached to the base cell, attached to the mast cell and basophil cell, they causes release of their vesicular content, and one of the vesicular content is tryptase. It is advised to take the sample within 15-30 minutes to 1 hour, and then the second sample at 24 hours. So when the raise in the serum tryptase is 1.2 times more than the baseline, it is indicative of IgE mediated perioperative anaphylaxis. And for the documentary proof, we need to undergo skin allergic test. So what are the difference between perioperative anaphylaxis under non-perioperative setting and perioperative setting? So the anaphylaxis happening in ICUs under sedation when patient is GA is called perioperative setting. Here, majority of the symptoms are cardiovascular, which are hypotension, tachyarrhythmias, and cardiac arrest. The skin sign, mucocutaneous sign here are not evident. Whereas in non-perioperative setting, the most common presentation are mucocutaneous signs. They are flushing, itching, and urticaria with upper or lower respiratory symptoms. So whenever we make a diagnosis, we should always have differential in our mind. As I said, anaphylaxis present with triad of respiratory symptoms, cardiovascular symptoms, and skin symptoms. So for the respiratory symptoms, the differential diagnosis are acute exacerbation of asthma. Various studies have postulated that the patient with asthma do not have a higher incidence of perioperative anaphylaxis. Their incidence of anaphylaxis in asthma patient versus a non-asthma patients are the same. There could be aspiration, there could be endotracheal tube malposition, there could be secretion, there could be pulmonary embolism. If we have transfused blood, we should consider transfusion-associated lung injury and pneumothorax. What are the differential with respect to the cardiovascular symptoms? They could be life-threatening arrhythmias, myocardial infarctions, cardiac tamponade, or there could be overdosage of vasoactive agent, air embolism, and partial sympathectomy as seen in regional anesthesia. For the skin, the differentials are angioedema and urticaria. So, based on this cardiovascular, respiratory, and mucocutaneous signs, the severity of hypersensitivity can be classified by modified Ring and Messmer classification, where the grade 1 involves mainly cutaneous signs. They are generalized erythema, urticaria, and angioedema. Whereas grade 2, they have measurable but not life-threatening systemic symptoms. They may have cutaneous signs like hypotension, tachycardia, and respiratory disturbance in the form of difficulty in ventilating and cough. In grade 3, they have life-threatening symptoms, which include major cardiovascular collapse, tachycardia or bradycardia, and bronchospasm. Grade 4 is a cardiac or a respiratory arrest state. So once we know what is anaphylaxis, what are the agents, and we have diagnosed, now how to proceed, how to manage. So immediately once we are suspecting that it is a case of anaphylaxis, we should immediately stop the administration of all the suspected allergens which we have given before the incident has taken place. Call for help, administer 100% oxygen. Like in any crisis management, we follow ABCD protocol. So A is secure the airway as early as possible if not already taken. B, control ventilation. C is initiate intravascular volume expansion with crystalloid being the first line of agent at a rate of 20 to 30 ml per kg body weight using a wide bore cannula. And the cornerstone for the treatment of perioperative anaphylaxis is adrenaline. It should be administered as soon as possible in a titrated dose to restore the blood pressure with an initial dose of 10 to 50 mics per bolus. The repeat bolus dose may be required if the pressure has not raised or in a patient who is beta blocked. If still the BP is not rising, we can consider continuous infusion of ADR. These are the doses of ADR depending on the grade of anaphylaxis. For grade 1, in an adult, we give 50 to 20 mics of IV bolus dose. For grade 3 reaction, we give 100 to 200 mics IV bolus dose. For grade 4, which is a cardiac arrest situation, we follow ACLS algorithm and we give 1 mg IV with ongoing CPR. If no IV access is available, we may consider intramuscular route on the anterolateral aspect of the thigh, and the dose is 500 mics IM or 0.5 ml of the drug. So once we have managed ABCD, what to do next? Additional fluid administration is dependent. We can consider invasive monitoring or echocardiography for administering further fluid. We can consider colloid for volume expansion, provided it is not one of the trigger for the reaction and we are not suspecting it to be the cause for the reaction that has occurred. In case of still, if the refractory hypotension persists, we can add vasopressors like noradrenaline and vasopressin infusion along with the ongoing adrenaline infusion. If the clinical condition deteriorates or the cardiac arrest situation happens, then we have to follow the ACLS guideline and CPR to be initiated. In case of a severe bronchospasm, we can consider nebulization using beta-2 agonist. We need to reassess our ventilatory mode, look for the IE ratio, increase the expiratory time. Corticosteroids should be given. It also helps to alleviate the bronchospasm. Role of Sugama-dex for rocuronium-induced reaction is controversial. The evidences are lacking. All these are case reports available, but it should only be considered as a last-line rescue therapy for rocuronium-induced anaphylaxis, as Sugama-dex itself is one of the triggers that can cause anaphylaxis. So once we have managed the crisis, ideally this patient should be shifted to the ICU. Hemodynamics needs to be monitored. Once the patient is fit and fit to discharge, we should give him a letter that contains the description of the entire reaction that has happened and what are the agent we have administered prior to the reaction. And referral to the allergic testing center is required to investigate the reaction and find out the actual causative agent, which may not be evident in 40% of the cases. And this the decision whether to proceed for the surgery or not. If it had been a grade 1, grade 2 anaphylactic reaction and the patient has been hemodynamically stable, and depending upon the urgency of the surgery, if it's an urgent surgery or emergency surgery, we can proceed. But severity after grade 3 increases the risk of event. Studies have found that there was no difference in risk between continued or abandoning the surgery. So decision to proceed surgery is an individual decision. It depends on the clinical scenario. It depends on the urgency of the surgery and the risk and the severity of the event and the stability of the patient being achieved. So now once we know once we have managed what to do, how to prevent the anaphylaxis from happening, 3% of the perioperative anaphylaxis that are occurring are recurrent in nature. So whenever we know this particular agent is responsible, always avoid the drug which is being tested positive for hypersensitivity. Consider any cross-reactiveness with other drugs, and general precautions like whenever we give IV drug, always give at a rate slow. Whenever we give antibiotics, which are the major trigger agent, always we should time the antibiotics given. Always give the antibiotic after a skin test. So to summarize, early diagnosis and prompt management of anaphylaxis is pivotal. Anaphylaxis should be considered if the cutaneous sign coexists with hypotension and a bronchospasm. So the mainstay of management for perioperative anesthesia are pulpo help and cessating the trigger, aggressive fluid management using a wide bore cannula, careful titrated dose of IV adrenaline, and it requires vigilant monitoring of the cardiovascular response as it is a drug with a narrow therapeutic window, and always reporting of such incident that has happened. Thank you.
Thank you, Dr. Kirti, for giving us an overview of the anaphylaxis management in the perioperative setting. So this talk was mainly if you have a crisis situation of unexplained hypotension or bronchospasm intraoperatively and possibly due to anaphylaxis. I would like to add on 1 or 2 points. some of the, like it may happen in the public place also. Many of the patients do have drug allergies. Food allergies are also very common in population, and sometimes the person may carry an EpiPen injection, which can be very much used in that situation. The eats food that person is allergic to, carrying that EpiPen injection that can be used in the similar way on the anterolateral aspect of the thigh, and it contains 0.3 milligram of adrenaline. It can save the patient in that crisis. Or as anesthesiologist, we may have a patient in the ER. Patient may come with a bee sting. Patient will usually present with swollen eyes, tongue edema. Hoarseness of voice is a very, very important sign to look for in such cases. And in those cases, as we know, the airway is not secure. Patient is walking to the ER, but situation may become very critical soon. So initially, although we can try a nebulization of adrenaline can also be tried, because it will reduce the laryngeal edema. It can help with the bronchospasm. It can help with the hypotension. But we need to consider early intubation, and we need to have our air cut with smaller endotracheal tubes, considering the airway edema that patient might be having. And all these things can be very much useful if we are outside the OR to manage anaphylaxis situation. So now for the next case, I invite Dr. Priyanka Gupta, who is assistant professor with us in VMMC and Safdarjung Hospital. She will start her talk on intraoperative desaturation. Priyanka, please start the talk.
Good evening all. Good evening all. Continuing with the series of lectures on anesthesia crisis resource management, my topic is intraoperative desaturation. A 62-year-old female obese patient with a BMI of 32 kg per meter square posted for total laparoscopic hysterectomy. On preoperative assessment, the patient was conscious and oriented with a heart rate of 76 beats per minute, BP 134 by 88 mmHg, 98% on room air. She is a ASA2 with normal cardiopulmonary reserve. On airway examination, mouth opening was more than 3 fingers, MMPG grade 2, short neck, and neck movements were normal. On systemic examination was within normal limit, and investigations were normal. Plan of anesthesia, general anesthesia with controlled mechanical ventilation with endotracheal tube was planned, and it was maintained with oxygen plus air plus sevoflurane. After pneumoperitoneum and tendon positioning, patient saturation decreases to 92% and remains between 92 to 94%. So in further slides, we are going to discuss what is desaturation, what can cause this intraoperative desaturation, and how will you manage it. Decrease in the blood oxygen saturation level can lead to hypoxia. Normal pulse oximeter readings should be between 95 to 100%, which corresponds to PaO2 of 80 to 100 mmHg. Saturation below 94% should be considered hypoxia. Pulse oximeter helps in early detection and correction of hypoxia. So what can be the causes of desaturation? Problem with oxygen delivery, patient-related factors. So coming to the problems with oxygen delivery, they can be at various levels. Central oxygen supply, they can be wrong gas, leak, inadequate pressure, failure of alarm system. At the level of pipelines, there can be leak, cross connection, wrong connection. The oxygen cylinder may be empty, partially opened, or wrong attachment can be there. And at the level of anesthesia machine, there can be problem with the flow meter settings. Oxygen flow meter can have cracks, they can be leak. At ventilator could have disconnection, low minute ventilation could have been set. And at the level of breathing system, there could be leak, disconnection, or obstruction. All this can be prevented by proper OT preparation. You should come on time, check your anesthesia machine, check for the oxygen supply, and be prepared for the first case in the OT. At the level of endotracheal tube, this is the most common cause of intraoperative desaturation in the patients under general anesthesia. There can be accidental extubation. endobronchial intubation, esophageal intubation, kinking of the endotracheal tube, obstruction by secretions, blood, mucus, and cough leak. So auscultation is utmost important. Patient-rated factors. Sedated patients who are spontaneously breathing can have hypoventilation due to drug-induced respiratory depression. As we all know, under general anesthesia, FRC decreases by 15 to 20%. This can be prevented by giving PEEP to the patient. There can be increased airway resistance due to bronchoconstriction, pre-existing conditions in the patient like asthma, COPD, or there can be endotracheal tube obstruction, bronchospasm. This can alert you by seeing your ventilator parameters. There can be increase in peak airway pressures. There will be increase and upsloping of EtCO2 curve. There can be atelectasis, which can be due to secretions, prolonged procedure, and absorption atelectasis with high FiO2. The thickening of blood-air interface, inflammation, edema, and fibrosis can lead to diffusion defects. There can be VQ mismatch. Atelectasis, aspiration, pulmonary edema can cause inadequate ventilation, while there can be shunt due to cardiac conditions like ASD, VSD, PFO. There can be poor oxygen delivery to the tissues in conditions like hypoperfusion, embolism, sepsis, or there can be increased oxygen demand in sepsis, shivering, malignant hypothermia. Now coming to the case-specific consideration. Laparoscopic surgeries are very commonly performed in today's era. Intraoperative desaturation is common in these surgeries. This can be due to pre-existing conditions in the patient like obesity, cardiopulmonary dysfunction. The pneumoperitoneum created can lead to endobronchial intubation. There can be pneumothorax, emphysema. The changes in position, like Trendelenburg position, can lead to decrease in FRC. Decreased venous return due to increased IAP, arrhythmias, CO2 embolism, or myocardial depression can lead to reduced cardiac output. Now coming to extremes of ages, neonates and infants are prone to rapid desaturation as they have smaller airway diameter, increased oxygen consumption, premature babies are deficient in surfactant. There can be easy fatigability due to lack of type 1 muscle fibers, making them more prone for difficult intubation, desaturation. In elderly patients, there is a physiological state of compromised respiration because there can be decreased compliance, decrease in vital capacity, and impaired gas exchange. They also have compromised cardiovascular system. Obese patients are considered difficult mass ventilation, intubation, laryngoscopy. They have decreased lung volumes like FRC, vital capacity, and they are very sensitive to depressive effects of hypnotics or narcotics. Pregnancy is a physiological state where we all know that FRC decreases by 15 to 20%. There is an increase of oxygen consumption by 20%. The increased chances of aspiration, chances of embolism. In one lung ventilation, there can be VQ mismatch, HPV, and atelectasis. In a patient with COPD, polytrauma, with blunt chest injury, or post-central line insertion, a high suspicion of pneumothorax should be made. So before going on to the next slide, I will ask you a question. At the end of the anesthesia, after discontinuation of nitrous oxide, 100% oxygen is administered to the patient to prevent diffusion hypoxia, second gas effect, hyperoxia, bronchospasm, or laryngospasm. Can we have the answer in the chat box? I can see that most of you have answered it correctly. It is diffusion hypoxia. So what is diffusion hypoxia? Also known as Fink's effect. It occurs during recovery phase after general anesthesia when nitrous oxide is used. As we all know, nitrous oxide is 31 times more soluble than nitrogen. So it rapidly diffuses out of the blood and into the air-filled spaces, leading to dilution of alveolar concentration and transient hypoxemia. This is more common during first 5 to 10 minutes of recovery and can be prevented by giving 100% oxygen to the patient for 3 to 5 minutes post suggestion of nitrous oxide. Now, after knowing all the causes and what can lead to intraoperative desaturation, let's come to the management of intraoperative desaturation. SpO2 of less than 94% should be assumed hypoxia until proven otherwise. Administer 100% oxygen, consider hand ventilation, check for bank compliance, and call for help. Confirm the probe position on the patient. Does it have a good waveform or no? If it is not, waveform is not correct, you can reposition the probe. If waveform is good and you then you have to think about the causes. Is the problem with the patient or is the problem with the equipment? And call for help and check your ABCDE. What is this ABCDE? This is a mnemonic which you can use and troubleshoot your intraoperative desaturation. And let A is for airway, B is for breathing, C is for circulation, D is for drug effects, and E is for equipment problems. These all will be further discussed in the next slides. Airway. Is the airway clear? If the patient is intubated, check for the proper placement of tube. Auscultate the chest. Check for your ventilatory parameters. Check, is the tube endobronchial? Is there accidental extubation or is there obstruction? And act accordingly. Is there secretions, blood or mucus plug in the endotracheal tube? Do suctioning. If the patient is not intubated, you can land up into unanticipated difficult airway, or you check for the signs of airway obstruction. Use head tilt, chin lift, consider jaw thrust, and consider using oropharyngeal or nasopharyngeal airways. Check for the signs of laryngospasm. So what are the signs of laryngospasm? There can be incomplete laryngospasm or complete laryngospasm. In incomplete laryngospasm, the vocal cords are closed, but with a posterior opening. So there is a limited airflow. So patient may have inspiratory stridor. There can be decreased air entry present in the chest. In the case of complete laryngospasm, there is no air entry, there is no EtCO2, the bag is not, the chest is silent. So how will you manage this laryngospasm? Keep the 7P approach in your mind. Pause. Pause the surgery or any stimulus which you are thinking can cause laryngospasm. P, personal. Call for help. You need extra hands in case of crisis. P, position. Position, use head tilt, chin lift, jaw thrust. Then pressure. As you all know, during laryngospasm, we give pressure at Larson's point. Then you can consider giving propofol in doses of 0.5 to 0.8 mg per kg IV. Or if this is not broken, then you can give paralysis with injection succinylcholine in doses of 0.5 to 1 mg per kg IV. Now coming to breathing. Is the patient breathing adequately? Check for your ventilator settings, airway pressures, respiratory rate, tidal volume. Do you suspect, check, auscultate the chest and check for bilateral equal air entry. If you suspect, do you suspect endobronchial intubation? Or there can be pneumothorax where there is no air entry on the one side of the chest, and you can consider ICD placement. Is there any added sounds like where you can consider bronchospasm? Now, bronchospasm you can detect by seeing by listening to expiratory V's. There will be increased airway pressure, decreased pulmonary compliance, and upsloping of EtCO2. So how will you manage it? You first have to call for help, administer 100% oxygen, hand ventilate, rule out all the anaphylaxis, all other causes like anaphylaxis, endotracheal tube positioning, or any obstruction. Maintain oxygen and ventilation, deepen your plane of anesthesia, and you can use pharmacological management like salbutamol puffs, IV steroids, and IV bronchodilators. Coming to C, is the circulation normal? Check for heart rate, BP, ECG, capillary refill time. If you suspect hypovolemia, correct it by giving intravenous fluids. Check for hemorrhage and consider blood transfusion. In case of septic shock, consider vasopressors. Now D, is your drug effects? You check for correct administration of all the anesthetic drugs. Is there any drug which can cause hypotension like volatile agents, hypnotics? Do you suspect methemoglobinemia, like drugs like SNP, NTG, amyl nitrate, prilocaine can cause methemoglobinemia, which you can treat by giving 100% oxygen to the patient and giving injection methylene blue in doses of 1 to 2 mg per kg IV. Do you suspect any inadequate signs of inadequate reversal of muscle relaxant or any adverse drug reaction? E, is the equipment working properly? Check, is there a problem with the oxygen delivery system to the patient? Check from the patient end to the machine end. In case of any equipment failure, you eliminate the circuit and take the patient on AMBU or Bain circuit. Now, once we know, I have seen how all you will use A, B, C, D, E. Now let's come to our case scenario and recapitulate. Ours was a 62-year-old female for laparoscopic hysterectomy. And after pneumoperitoneum and tender positioning, the patient's saturation dipped to 92% and remained between 92 to 94% with the EtCO2 of 34 mmHg and hemodynamic stable. How will you manage this case? Call for help. Give 100% oxygen. Auscultate the chest. Check the chest compliance of the chest, but don't forget your ventilator settings. See for airway pressures. Check hemodynamic parameters. Check for any adverse drug reactions and check all airway connections. After ruling out your failure to oxygen delivery to the patient, we can make a differential diagnosis of related to this case. There can be endobronchial intubation, as pneumoperitoneum was created in this patient, which can lead to capillate shift of diaphragm and your carina and can cause endobronchial intubation. There will be increased EtCO2, increased peak airway pressures, but BP will be normal. There can be obstruction of endotracheal tube due to secretions, kinking. There can be atelectasis due to pneumoperitoneum created. The tender positioning will decrease the FRC and patient is already obese and elderly. There can be bronchospasm. You will see increase in EtCO2, peak airway pressures will rise and BP will be normal and the management has been already discussed. Anaphylaxis has been very well taken by the previous speaker. There can be pneumothorax. There will be increase in EtCO2, peak airway pressures will rise and BP will decrease in pneumothorax. There can be CO2 embolism where EtCO2 will decrease, peak airway pressures will increase. There can be arrhythmias and hypotension in this patient. So after ruling out all the causes, what can be the most probable diagnosis in our patient, as she had intraoperative desaturation with normal EtCO2, with normal peak airway pressures and no hemodynamic instability. So we can make a probable diagnosis of atelectasis. What are the factors supporting our diagnosis? Patient factors: patient is elderly, obese. There can be surgical related factors are laparoscopic, pneumoperitoneum was created, and positioning, tender position was done. So what will be the most appropriate step for this, for the treatment of this situation will be addition of PEEP. Now, MCQ for you guys. A 5-year-old pre-fit patient is posted for tonsillectomy. During inhalation mask induction, you are unable to ventilate the patient and saturation of child starts to fall from 99% to 90% and further decreases. What can be the most probable cause? Bronchospasm, laryngospasm, pneumothorax, atelectasis. Can I have the answers in the chat box? Yeah. Yes, it is laryngospasm, as it is during inhalation induction before intubation, and this is almost a complete laryngospasm. So what is your take-home message from today's lecture? In the time of crisis, keep yourself calm, call for help, and don't forget your A, B, C, D, E. These are my references. Thank you.
Thank you, Dr. Priyanka Gupta. This was a very interesting talk on intraoperative desaturation, and the table that you have shown to make the differential diagnosis. I think that is going to be very useful for our postgraduate residents, that it is not only the parameters on the monitor, the vital signs, it is also the ventilatory parameters that needs to be monitored critically during the anesthesia and perioperative period, because they can give a lot of information about the patient condition, and also the ABCD approach to the management of intraoperative desaturation. That was very helpful. One point I want to add here, when you have mentioned about the laryngospasm in a child when the IV line is still not in place. So I can put it a question to the residents that what will they do, which drug is to be used, and what route they will use to give that drug to manage that laryngospasm. You can put your answers in the chat box, and if we have time at the end, we will discuss, or I will post the answer in the chat box itself after the next talk is completed. So now I invite the last topic for the day, and I invite Dr. Krishika Verma, who is Assistant Professor at VMMC and Safdarjung Hospital, to present her topic. Dr. Krishika Verma, please.
Thank you, Team ISA, for giving me this opportunity. So continuing with the series of ACRM, my topic is local anesthetic systemic toxicity. So I will be starting with the case scenario. So 68 years old male patient who is a known case of hypertension and chronic renal failure with the diagnosis of fracture of proximal humerus and shaft of humerus. He came in emergency, posted for open reduction and internal fixation. Preoperative assessment, the patient is conscious and oriented, but pallor was present. There was no icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Vitally, the pulse rate is 72 per minute. The BP is towards the higher side. It is 132/82. Respiratory rate is 16 and saturation is 98% on room air. He was afebrile to touch and a BMI of 22.6 kg per meter square. A dialysis catheter was present in the left side of femoral vein. Airway examination was fine. Systemic examination seemed fine. Regarding the investigation, the HB is 9 gram per deciliter when the KFTs are abnormal. Urea is 90 milligram per deciliter and creatinine is 3.5 milligram per deciliter. Regarding the ECG, he is having a normal sinus rhythm, but LVH was present. Echo finding were grade 2 diastolic dysfunction and an ejection fraction of 40 to 45%. He underwent a hemodialysis 24 hours prior to surgery. So our plan of anesthesia was ultrasound guided interscalene block with catheter in situ. As it was involving 2 fractures, the surgery is going to take long. So patient was shifted to operation theater. All the monitors were attached, an IV line was secured, and 20 ml of 0.5% bupivacaine was given in interscalene block and catheter was inserted. Now the scenario progressed. So after 2 hours, infusion of 0.5% bupivacaine was started at 4 ml per hour. Soon after that, the patient complained of generalized discomfort, perioral numbness, and metallic taste. Patient become agitated, followed by seizures, and become unresponsive. Vital signs taken was heart rate of 112, and the BP goes to a higher side, that is 150/96, and saturation went to 96% on room air. So immediate resuscitation was done, and 100% of oxygen was given via closed circuit. 1 milligram of midazolam was given for the seizures. Side by side, call for help was sent, and the last was suspected, and we have asked for 20% of intralipid. Airway was secured, and in no time, the patient developed cardiovascular signs of toxicity, arrhythmias occur, and followed by cardiac arrest. So what are the differential diagnoses? First is a seizure disorder. Second, it may be due to any drug. It may be anaphylactic reaction. It may be a hypoglycemic event as the patient is of CKD. So it may be possible the patient is having a hyperkalemia and followed by cardiac arrest. And lastly, we have a last diagnosis, that local anesthesia, systemic toxicity, because the patient is of old age, patient is a CKD patient. So it might be possible that the patient may have a systemic toxicity of local anesthesia. So to know the chances, the incidence of last is very low. It is 0.87 to 1.8 per 1,000 individual. So to put it in perspective, it is just like having a breast cancer in men or odds of winning a small lottery, a chance of being hit by a bus while crossing the street. So regarding the basic structure of local anesthetic, so as you all know, local anesthetic is made up of aromatic portion, that is a lipophilic portion, and an amine portion, that is a hydrophilic portion. And there is an intermediate chain which define the local anesthetic. If it is an ester chain, then it is an amino ester. And if it is an amide, then it is an amino amide. Now, what is the basic difference between an ester and an amide? So ester, we all know, we have cocaine, chlorcocaine, and prilocaine. So esters are rapidly metabolized by plasma cholinesterase. So systemic toxicity is very less. So they get metabolized into para-amino benzoic acid, which is responsible for its allergic reaction. Whereas the amides, they are slow. The metabolism is by liver and the systemic toxicity is more. Whereas the allergic reaction are very rare. Regarding the onset of action, the esters are very slow as a general rule. Whereas amides, they are moderate to fast. Now a word about pKa. So what is pKa? So pKa is the pH at which the local anesthetic is 50% ionized and 50% non-ionized. So closer it is to the physiological pH, the more faster the onset of local anesthetic. So for an ester, it is higher than the physiological pH. That is 8.5 to 8.9. That's why they have slow onset of action. Whereas in amides, it is closer to physiological pH. It is 7.6 to 8.1. That's why they are moderate to fast. So in the amides, whatever we are using, bupivacaine, lignocaine, they are all amides. Now a word about mechanism of action. So local anesthetic, they block the conduction of nerve impulse. So generation as well as conduction. So they block the sodium channel. So what happens is local anesthetic in an unionized form, they crosses the cell membrane and they convert into ionized form. So ionized form get attached to the alpha subunit of the sodium channel, thereby blocking the influx of sodium channel and inhibiting the nerve impulse. Not only they act on sodium channel, they also act on potassium channel, calcium channel, and sodium potassium ATPase. But they have a higher affinity, but this binding is reversible and this is concentration dependent. They have higher affinity for open and inactivated sodium channel. So what are the risk factors of local anesthetic toxicity? The first and foremost is patient factor, which I will be discussing in the subsequent slide. Second is site of injection. So higher the risk of intravascular injection in blocks such as intrascalene block, stellate ganglion block, which is near to the vasculature, like in the lumbar plexus block, there are high chances of intravascular injections. At the site where high absorption of local anesthetic, like we have a scalp, pleura, so chances of toxicity is much higher than we think. So the risk from lowest to highest comes from tumescent anesthesia, which have a lowest risk, to the highest, that is the intravenous, followed by tracheal, intercostal, caudal, epidural, brachial plexus, sciatic, femoral, and subcutaneous. So everyone are doing fiber optic intubation. So care must be taken while doing a fiber optic intubation and calculating the dose of fiber optic local anesthesia. As the dose is already high, but still the chances of toxicities are also high. The next is the type of local anesthesia whose ratio, that is a CC upon CNS ratio. So it is a ratio of the drug which is responsible for cardiovascular effect divided by the dose which is responsible for the CNS effect. So lower the ratio, higher the risk. So bupivacaine is having a CC upon CNS ratio of 2. That's why the bupivacaine is more cardiotoxic. Whereas the lignocaine, this ratio is 7.1. It depends upon the mode of administration, whether it is a single dose or a continuous infusion. Now coming to the patient factor. So first I'm taking the extremes of ages. So what happen is local anesthetic, they combine to alpha acid glycoprotein, which are there in the liver. So in the state where there's a decrease in AAG, so there's a free fraction of local anesthetic increases. That is what happened in the neonates. And moreover, there's decrease in the clearance. So we have to decrease the dose in neonate. So dose decreases up to 15%. Now what happened in geriatric age group? There's increase in the neuronal susceptibility for local anesthetic plus decrease in the clearance. So it is advisable to decrease the dose of 20% in geriatric age group. Now what happened in pregnancy? Again, there's a decrease in alpha acid glycoprotein, so free fraction increases. There's decrease in pseudocholinesterase, plus the gravid uterus is compressing the epidural veins, so that is responsible for decrease in CSF volume. Thus, the pregnant patient, they are more susceptible for local anesthetic because of the hormonal changes and increase in the progesterone. Now we come to the pathological things. First is a chronic kidney disease. In the chronic kidney disease, just there in our case, they are having a hyperdynamic circulation. So the systemic absorption is more in these cases. Moreover, there is decrease in the clearance. So what happened in the chronic liver disease? There's more of the free fraction of local anesthetic because there's a decrease in the alpha acid glycoprotein. So metabolism is decreased. But care should be taken care in the repeated doses, not in the single doses. It is unaffected. Now, what happened in the congestive cardiac failure? They're already having a low cardiac output, so they are more prone to arrhythmias and the perfusion is also affected. So these all are high risk cases. So when we give local anesthetic towards the nerve, so some of the local anesthetic get deposited surrounding the nerve. So some of them binds to the non-specific local tissue binding. Plus rest of them goes inside the blood where it gets metabolized. If it is ester, then it is metabolized by chlorine esterase. If it is amide, it gets metabolized by hepatic metabolism. Now what happened to the excess of them? The excess of the local anesthetic, they goes to brain causing a CNS toxicity. They goes to heart for cardiovascular and plus other rest of the systemic tissue. Now coming to the mechanism of last. So there are two possibilities. First is the delayed onset, which is via systemic absorption, and second is a sudden onset. So it doesn't give us time. So while giving the block, the accidental intravascular injection do happens and patient precipitate the last. So what is the mechanism of CNS toxicity? Initially, blockage of amygdaloid complex causing blockage of inhibitory pathway in the cerebral cortex. So what happens is excitation occur. So patient present with tingling, seizures, perioral numbness. But at the higher plasma concentration, excitatory pathway is also affected, leading to CNS depression. So what happened in the cardiovascular system? So it blocks the sodium channel, which is responsible for the conduction defect. It blocks potassium channel, which is responsible for arrhythmias by prolonging the QT interval. It also inhibits the sodium-potassium ATPase, plus inhibition of calcium leads to decrease in the calcium and decrease in the cardiac contractility. At higher doses, peripheral vasodilatation causing hypotension. We all know that the local anesthetics are all vasodilatory except cocaine. So it causes peripheral vasodilatation causing hypotension, and it inhibits the carnitine, acylcarnitine translocase. Therefore, ATP generation is also affected. Now, why bupivacaine is more cardiotoxic? So it acts on both active as well as inactive voltage gated sodium channel. So because of the lipid solubility, there's a fast in action, but there's a slow out action. So more lipid soluble, unionized form available. So faster membrane penetration, and there's a slow dissociation. As I have already explained, it has a low CC upon CNS ratio, which is 2. It has a vasodilatory effect, and it is difficult to resuscitate. So what is the clinical presentation? So here, when a typical LAST occurs, typical LAST has a presentation of first, there's a CNS feature followed by a cardiovascular feature. So excitation first and inhibition second. So CNS excitation, then inhibition, then CVS excitation and cardiac arrest. So excitation, the first thing we generally notice is perioral tingling and tinnitus. Some patient may present with tremors or slurred speech. Patient become very agitated, confused, metallic taste and seizure, followed by depressive phase, which includes loss of consciousness, coma, and finally respiratory depression. In this cardiovascular system toxicity, there's an initial phase of hypertension and tachycardia, followed by intermediate phase, which is hypotension, and a terminal phase where the patient is severe hypotensive, arrhythmic, and followed by cardiac arrest. But this is a typical picture. There are scenarios where there's no CNS feature and the patient directly land up to the cardiac arrest situation. And there are scenarios where only CNS toxicity is there and they may not progress to cardiovascular toxicity. So this is not a rule. Atypical pictures have been found. Now, how can we prevent this? While no single measure can eliminate the risk of LAST, so a thorough pre-operative evaluation, and we should assess who are the high-risk patients. So it is always vital to keep an emergency drug and resuscitation equipment ready. So 20% of intralipid emulsion should be available all the times where the blocks are being performed. A standard ASA monitoring should be done. And while doing the timeout, you should always discuss the dose of local anesthetic before the procedure. So use of lowest effective dose of local anesthetic, which is based on lean body weight, is advisable. Sorry. A dose reduction of 15% is advisable in neonate and infants, and a dose reduction of 20% is done in geriatric patients. So you should avoid deep sedation. So as I have explained that sometimes the patient present with euphoria, agitation. So these may be missed if GA is there. So we should avoid it. Give the test dose with adrenaline before injection. Aspirate before injection to rule out vascular injections. Slow incremental dose. So we should give an aliquot of 3 to 5 ml of drugs and having a gap of 30 seconds to see the effect of drug. It is always advisable to use an ultrasound guided blocks and avoid blind blocks whenever possible. Strict monitoring should be done and communicate frequently with the patient to detect the symptoms of LAST. So these are the recommended dose of local anesthetic, which you can see later. So although there are studies to guide the dosing of individual LA, there have not been studies to guide the dosing when administering a multiple local anesthetic simultaneously. So many a times it is seen that we are taking a bupivacaine plus lignocaine mixture. So it is not advisable, but if you are giving, so care must be taken. So you should not exceed the combined maximum dose. So the current recommendation are not to exceed the combined maximum dose. Meaning if you have given a 50% of maximum dose of one agent, you should not administer more than 50% of the maximum dose of other agent. So this is the checklist for the treatment of local anesthetic toxicity, which is given by the American Society of Regional Anesthesia and Pain Medicine. So this I will be explaining in my subsequent slides. So now the LAST has happened. So what will you do? So stop injecting. First and foremost, stop it. Call for help. consider the lipid emulsion therapy at the first sign of the serious last event. Alert the nearest cardiopulmonary bypass team and manage as per ABC. Secure the airway and give 100% oxygen. Avoid hypoxia, hypercarbia, acidosis, and control seizures. So these are very important. Why these are important? Controlling seizure is important and securing the airway is important, because if they are not done at right time, so it may lead to hypercarbia, and which may lead to acidosis. So when acidosis occur, there is an increase in the free fraction of local anesthetic. So it further precipitates the toxicity. So care must be taken to avoid these things. Treat the hypotension and bradycardia. If pulseless, start CPR as per ACLS guidelines. Cardiopulmonary bypass or extracorporeal membrane oxygenation should be considered in patient refractory to treatment if the options are available. So this is a trivia time. So can we use propofol as a substitute for lipid emulsion? Here we have, I have shared. Chat box, can I see the answers? No.
It's no.
Right.
Most of them have written no.
Yes, it's right. So propofol is not a substitute for lipid emulsion due to its potent cardiodepressant effect at a quantity that would be required to deliver the necessary lipid mass. So as you all know, that the lipid emulsion is made up of 20% of soybean oil, whereas propofol is made up of 10%, but still we cannot use propofol because the quantity is so much that it will further exaggerate the cardiodepressant effect. So this some word about the lipid emulsion therapy. So it is a 20% lipid, so the dose is for a more than 70 kg patient. 100 ml bolus should be given rapidly over 2 to 3 minutes, followed by 200 to 250 ml infusion over 15 to 20 minutes. For a less than 70 kg, it is 1.5 ml per kg bolus, rapidly over 2 to 3 minutes, followed by 0.25 ml per kg infusion. So we can repeat the bolus and we can increase the dose of infusion double if there's a persistent cardiovascular instability. So but care must be taken that the maximum dose of intralipid emulsion is 12 ml per kg. So while doing resuscitation, 500 ml to 1 liter of lipid emulsion can be given. So care must be taken care. So the Association of Anesthetists of Great Britain and Ireland guidelines recommended that 20% of lipid emulsion should be available immediately in all the areas where potential toxic dose of local anesthetics are being used. So what is the difference between our last resuscitation and ACLS guidelines? So instead of prioritizing the rapid cardiac support, so successful last treatment depends on early airway management. So the reason is that you have to prevent the hypoxia, you have to prevent the hypercapnia and acidosis. We don't want to increase the toxicity by increasing the free fraction of local anesthetics. So early infusion of lipid emulsion is must, as evidence exists that lipid shuttling is the most effective if giving early in the last event, and adverse events of administration are minor. So bolus of epinephrine should be less than 1 mic. So in a standard ACLS, we are giving a 1 milligram. Here it is less than 1 mic because to counteract the arrhythmia. So it may precipitate arrhythmia. So therefore, we should decrease the dose. Avoid other local anesthesia if arrhythmias occur, like lignocaine. Injection amiodarone is the drug of choice, and we should avoid beta blockers, calcium channel blockers, and vasopressin. So a word about 20% of lipid emulsion. How do they act? So there you see that the lipid emulsion, they bind to the local anesthetic and they form a lipid sink. and they wrap around it and remove it from the various tissue and organ. So it combines the LA in the heart and the brain. So, and it redistributes them to the liver and muscle for detoxification. And this is known as shuttling effect. But there are limitations of every drug. Lipid therapy is unfortunately not a panacea, and deaths from LAS continue to occur even when the lipid infusion has been administered. This can occur if the tissue local anesthetic load is simply too high or given too late or underlying cardiac function is poor. So monitoring after last event, monitoring for a if a cardiovascular event have occurred, so we should monitor at least 4 to 6 hours. And if a CNS event have occurred, so monitor at least 2 hours. Admission to ICU in case of cardiac arrest for post-resuscitation care. Now the question part. First question is, the following factor affect the speed of onset of peripheral nerve block except degree of local anesthetic ionization, lipid solubility of local anesthetic, proximity of local anesthetic to the target nerve, and protein binding of anesthetic agent. Can we have the answers?
Answer D, they have given, ma'am.
Okay, the maximum people have given a correct answer. So correct answer is D only. So the first option is degree of local anesthetic ionization, that is a pKa, which depends the speed of onset. Second is a lipid soluble. More the lipid soluble, fast in the action. Third is a proximity, which defines that more proximal, then faster the onset. But the protein binding depends the duration of action, not the speed of onset. So more protein binding, so more duration of action. Second question, regarding the intralipid and its role in anesthetic toxicity, which statement is true? Intralipid is not used in the treatment of tricyclic antidepressant overuse. The initial loading dose when treating last is 15 ml per kg. Propofol can be used as a substitute when intralipid is not available. CPR may have to continue for an hour after administration of intralipid. Intralipid should be given only in the cardiac arrest situation. So, what's the answer?
Given a C and one answer is from B, for B.
We have to identify a true statement. So here emphasis is, the correct answer is D actually. So I want to say that the intralipid can be given in the treatment of antidepressant overdose. So basically the intralipid is for the lipophilic drugs. So like beta blockers, tricyclic antidepressant, we can give intralipid as an antidote. So second option is wrong. And third option I have explained, propofol cannot be used as a substitute. Regarding the fourth, the CPR has to continue. So we should not lose our hope. We should continue our CPR. It may last hour or more than hour, and people are survived even after that. So CPR has to continue. And E is intralipid should be only be given in cardiac arrest? No, it can be given in the pericardiac arrest situation also. Lastly, I would like to end by saying that safety of local anesthetic relies not only on the drug themselves, but also on the skills and knowledge of healthcare provider administering them. So these are my references. Thank you.
Thank you, Krishika, for taking us through the clinical presentation, differential diagnosis, and how to manage local anesthetic systemic toxicity. And as Krishika has emphasized, that these patients may need prolonged efforts at resuscitation, and we should not give up on CPR in such patients, as we know it is kind of a drug toxicity. So in drug toxicity, the CPR ACLS guideline also say that till the antidote is given, till the drug is removed from the circulation. And intralipid is kind of an antidote for the local anesthetic. So prolonged resuscitation efforts are to be done in cases of local anesthetic systemic toxicity in case the arrest happens. And now I hand over the proceedings to Dr. Madhuri for taking us further. Thank you.
Thank you, madam. Dr. Anu, just check if there are any questions in the chat box which madam has to answer.
No, ma'am. All the questions were answered in the chat box, even, ma'am.
Okay.
We have tried to answer along with the presentations, but if there is anything else,
No,
that
ma'am. Not everything was answered.
If anybody wants to ask questions.
Actually, in between, you asked us one question that what route of drug has to be given during the saturation, desaturation, other than IV, without an IV.
Yes, yes. And one of the participant has answered that so if the child gets features of laryngospasm at the time of inhalational induction and we are still not secured the IV line, intramuscular use of succinylcholine is recommended at this step. Because lower dose of succinylcholine, you may not give the full 0.5 to 1 milligram per kg dose, because the idea is to relax the laryngeal muscles, and it will help in ease of the ventilation will improve, and your patient will come out of that crisis situation of laryngospasm, and then you will be able to effectively mask ventilate the child, secure the IV line, and proceed with the induction. Even endotracheal intubation can be done. So intramuscular succinylcholine is the answer, and one person has answered in the chat box.
Dr. Anjali. Yeah, it was
Yes,
a
sir.
beautiful effort by all four of you. You have prepared the things well and presented in a very concise and comprehensive manner. The last slide of the last, that was one of the most causative factor for the last toxicity. Krishika, you can go through that slide again. That last slide, just want to show it to the public before thank you. Yeah, this one. This one before that.
The quote.
The quote.
The quote.
Yeah. This one. See, the safety of a local anesthetics relies not only on the drug themselves, but also on the skill and knowledge of the healthcare providers administering. This is the factor you missed in that causative factors for the last toxicity. The most common, the most important factor is the anesthesiologist efforts and errors, as well as the vigilance during administration of the local anesthesia during a blocks or during any other injection, So this is the most common important factor, the single most common factor. The other factors are supplementary or complementary to this exercise of anesthesiologist. We say anesthesiologist because we are putting the block, whether it's ultrasound guided or it's a blind. So this is the single most factor never mentioned in the books. We always go to the factors, this is the common, the absorption mechanism, the directly injecting into the intravascular compartment. But the vigilance, the skill, the eyes are in the fingers of the anesthesiologist. So if you can exercise this, and the learning curve depends upon these factors. And regarding general principles, it's a very common thing, whenever the drugs are injected, they are having some excitation. The excitation has begun. That means the majority of the drug has already bound to the receptors and have started exerting their actions. So they're bound to be a depressive phase also after that. You have to prepare yourself. That excitation has occurred. It may or may not be followed by a depressive phase of the drug toxicity, but you have to prepare for the depressive phase, which is more dangerous than the excitation actually, where the maximum cardiac arrest occurs. So when the excitation occurs, so you prepare for the depressive phase of that drug. And invariably, all the long-acting drugs, it's not just bupivacaine, it's all the long-acting drugs have a longer duration of action. Once they are bound to the receptors, it's very difficult to dislodge them. There has been no antidote for any local anesthetic toxicity. The wrap zinc you're talking about, the lipid emulsion, it is basically to clear the unionized drug in the bloodstream, which is still not bound to the receptors. The rest of the drug will wear off with the time, when their half-life is, completed. So those things will keep on happening till the drugs get dislodged from the receptors. And regarding the cardiac tissue effects, they say sometimes the CNS may not be followed by the CVS effects. Actually, what happens, you see all the studies where there has not been a proper clinical trial where you can see the comparison of the toxicity of local anesthetics on different age groups, on different, type of subset of patients. These are the anecdotal case reports or case series where have you accumulated the evidence of the local anesthetics really exert their toxicities. In the CVS, wherever you have found that CVS has been impacted are those cases where already the patients have some a pre-morbid cardiac condition or the age factor and other factors. You will not see the typical CVS factors getting involved simultaneously unless and until the dosage of intravascular injection is large. The CVS may not be getting impacted, but CNS is invariably impacted as the first sign of toxicity. But majority of cases it will lead to CVS, but you will be able to resuscitate the patient which have got the minimal CVS involvement pre-operatively, pre-injection basically. So the CVS health is very, very important in determining the outcome of these patients with the intravascular injection of the drugs. And most importantly, the drug mixture, we are using the different drugs, considering that, okay, we use half of this drug, half of that drug, so that we will be able to obviate the side effects of one and we'll get the maximum advantage of the others. It's not like that. 90% of the time, the receptors are the same. You are going to exert the local anesthetic action on the same receptors, whether you use the longer acting or a shorter acting mixture, or you're using the longer acting mixture of the two drugs. The site of action is same. The dose equivalence of getting the superior effects with the minimal side effects is very difficult to determine. You go to any research study, you will never be able to see what were the plasma levels of the unionized form or the bound form, or even if you go to the molecular level studies, it's very difficult to define whether the mixture is really going to help or is going to reduce the toxicity of the drugs. So those factors actually we always consider arbitrarily, going by whatever the evidence we have got till day in the literature that, okay, we use these two mixtures, the side effect is less. But I think I can convey here that whatever mixture you use, it is again that single most factor is the last slide which you show, anesthesiologist factor. Rest all factors, they are the factors which we always give in support of the toxicity, which are the positive factors. The single most is anesthesiologist, whether in the periphery or in the academic institution. I've seen the drug toxicity even with the ultrasound guided blocks also. People are doing. So it's not the, the vision. Under vision also, that means the direct vision, you are visualizing the nerve and blood vessels, you are still causing toxicity. The single most factor, I think 90% of the factor is anesthesiologist factor. Rest are all secondary factor too. I think even the textbooks also have to be defined in this term. Whatever we get in textbooks, they are assuming that anesthesiologists are very superior human beings. They are not going to cause errors. But it is an error which is causing toxicity rather than the drug itself. So this is my just summarization of the entire thing. The rest for the anaphylaxis and the other one also was very good. Dr. Anjali has prepared everything, the team in a very good manner. The real crisis resource management team, I think. So you have done a very justification to the presentations. I think you already have got the compliment from the public, from all the seniors
Thank you,
also,
sir.
that
Thank
they
you
have
so
you have
much.
presented well. And I echo their, the vocabulary, whatever they've conveyed about the classes today. Thank you very much for this.
Thank you, sir. And I thank my team and the support team of the ISA National for the flawless proceeding of the event. And thank you so much from all of us at Safdarjung Hospital. Regards from our team back home also, like from our hospital. Best wishes for the ISA National activities. Thank you.
Now I want anybody to, Madhuri has raised hand, she can come, and other people also.
Yeah, this is just for the benefit of the PGs. Like, the usual question is, what is the difference between anaphylaxis and anaphylactoid reactions? And whether anaphylactoid reactions can also lead to a life-threatening crisis? And what is the difference between the two?
So I think Kirti is there.
So,
Kirti was presenting the anaphylaxis.
yeah, Kirti. Dr. Kirti, actually,
Oh.
anaphylactic, yeah, if she's
Yes,
not
ma'am.
on,
I'm here, ma'am. So, all the allergic reaction, anaphylactic reaction, which are IgE mediated, are called anaphylaxis. Any pathophysiology which do not involve IgE, the non-IgE mediated reactions are called anaphylactoid. But this term is no longer used because there are other mechanisms also, like we see drugs like atracurium, cisatracurium, they're directly going and releasing the histamines from the mast cells. So the term anaphylactoid is nowadays not used. And the IgE mediated reactions are more because since the sensitization has already happened, the reaction tends to be more severe when compared to the other reactions which are happening.
so you whether it is IgE mediated or not, it is anaphylaxis, that means, right?
Yes, ma'am.
Okay.
Now it is
And-
only anaphylaxis which is used. Anaphylactoid term is no longer used.
Okay. And what is the role of artificial intelligence in crisis management?
Yes.
And this is not. I
Because
don't. I will
of
answer this. I will say. I will not put
Yeah.
the artificial intelligence into this scenario where we are having the post graduation classes, because the postgraduates are supposed to use the books and other things in answering everything. They cannot resort to the artificial intelligence. For them, the involvement of the artificial intelligence zero in their post graduation career. They even for the writing the thesis or anything, if they resort to even 0.01% of artificial intelligence, I think Dr. Anjali Kochar will make them fail in the examination also. So at the role of at the postgraduate career, AI is not used. Even after that, still the controversies they are increasing day by day, even for your the research projects or whatever you're writing also for the chat GPT or artificial intelligence. They are just to support the human errors.
Yeah.
I think to some extent where the language part is weak, where the other things are, not
They
up to the
can
mark.
have a huge role in training in ACM, ACRM.
Those are workshop oriented is different thing. I'm talking
Yes.
about the educational system. In the
Yes.
educational system, artificial intelligence is zero role till your postgraduate career is there, because this is a medical specialty is entirely dedicated to the human safety. Artificial intelligence cannot replace a human mind where empathy, sympathy, and so many factors are there which are concerned with the human safety. Artificial intelligence is just to create a simulation atmosphere where you can have a training, where you can have a learning, where the learning curve can get faster. But in the when you imbibe the knowledge for patient safety factors, whatever you are imbibing in your postgraduate curriculum, I think even when these type of notions will come in the syllabus, I think NMC will not be able to highlight or will include in these things in there. After this thing, I think when you are already a graduate, postgraduate, you learn anything, then I think in the workshops and other CMEs, wherever you want or wherever the learning programs are there, you can use it for a faster learning, but not for acquisition of the basic human skills. Nobody can replace your nerve tracts. Nobody can replace your thought process. Nobody can replace your intelligence quotient, emotional quotient. Those things are irreplaceable even with artificial intelligence. This is only a place. It has a place in the future, but the time will come. You will have, I'm telling you, write it down today. It will have not more than 20% of the place even in the future also. You will again be back because so many technologies have come and gone. They have stayed only for a while. They may still staying in our lives, but not more than 20% will have its effect, the artificial intelligence, even the future course also. What we have gained as evidence as the policymakers in the administration over the entire country and globe. So artificial intelligence is, I think people are using it, misusing it, both sides. And misuse will be more in the coming days. So whenever misuse is there, the things will be reduced. There will be curbs, there will be things. And even in the journals, if you write answers according to artificial intelligence, those articles will be rejected because even now there are terms are being used in the declaration, the conflicts that you have to declare how much artificial intelligence or chat GPT or software you have used for defining those things, for writing those things. So in the coming times, I don't think so more usage than 20%. That is a maximum giving, it may be lesser than that. This is from my side as a policymaker, as an administrator, artificial intelligence may be staying in the future, but not for when the patient safety, the patient's emotional quotients and the intelligence and other things are the basic human skills are there. This is the take from my side. I think everybody's getting silence or thinking what to answer now. See, the postgraduate career, stick to your books. No space for artificial intelligence in the postgraduate career. Simply no, straight away no. I think Pavani, you are she's the director of the Cancer Institution.
Yes,
How
sir.
much artificial intelligence is going to help you there in your cancer institution? I don't think the person having a going to the end of life care, going to the emotional part is almost draining for that patient. Is the artificial intelligence going to improve the prognosis and the whatever other factors associated with his life remaining? You can answer better, I think, as a director of the cancer institution. I know your history also. I don't want to explain that, but this I'm talking about a particular this cancer patients.
Yes, sir. I think it helps in the treatment areas. Nowadays, so many people are creating artificial algorithms about the outcome and the habits, like tobacco chewing. It's way high in Northeast people. So all the algorithms, the case history, and they are using artificial intelligence in such scenarios. And even for like in remote areas in Northeast, we use artificial intelligence for X-ray reporting.
Those are the theoretical parts. I'm talking about the real practical parts in the cancer treatment of the patients. Will it going to replace the human intelligence there when you're treating the cancer patients like that? I don't think so, because these are a different subset of.
My husband wants to answer this one.
Yeah. Dr. Venkat is there.
Good evening, sir.
Good evening. Good evening.
Thanks for asking that question, sir. So you are absolutely correct, sir. Bang on that. No artificial intelligence or machine learning algorithm can ever be replace the human touch, particularly the counseling part. As Pavani said, we may do X-ray, but to discuss the results of X-ray with the patient, except for the human touch and emotions, particularly in oncology and end-of-life care, palliative care, it will not be possible to replace the human touch and human counseling. Sir.
Yeah, thank you very much. I expected this from you. The way both Pavani and her husband, they are taking care of the bigger cancer institute in Tejpur. Tejpur is in the border state of, which is just near the Arunachal Pradesh, where usually used to get attacks from China. So they are doing the service in that great area, in the borderline, in the borders territory of the country, and they're catering to the cancer patients. And if you ask me, the terrain, the topography is very difficult to get the cancer treatment in those areas. They have established themselves there, and both of them are doing a wonderful job. Hats off to you, the couple, and your team also.
Thank you, sir. Thank you so much.
Yeah. Dr. Madri want to ask certain things. Yeah, Dr.
No,
Madri.
I don't want to ask, but I just wanted to say that I never meant to say that AI can replace
No,
humans.
I am not
They can never
contradicting
replace,
for the
but I just,
postgraduate.
yeah, they can probably assist.
Hmm.
That too, that is also just coming up. Like there's nothing like that. It probably to
That's why.
assist our management when all hell breaks loose. Of course, clinical judgment is very important, but to improve our accuracy and to increase our speed of management, should we use these for assisting us? That's what I wanted to ask.
I think we are
They
already.
can never replace. There is no. I
Dr.
fully
Madri,
agree with you,
if-
sir, that we cannot
Dr.
replace.
Madri, if you ask me honestly, we are already using the AI. Everybody using the mobile, the software, the apps. Those are nothing. These are AI only. Whatever we are using, even the technical part, if you ask me, the monitors. If you ask the monitor, a monitor is there for measuring your
Means-
this one, the invasive, non-invasive, then the
Means-
ventilatory parameters.
Correct.
So everywhere you are using AI to some extent, but
Yeah.
overall that AI has to be managed by a human.
Yes.
Especially the postgraduate career, the main stress is on how to develop your own basic human skills and clinical skills, the acumen, how to deal with the patients rather than relying solely upon the technology. The technology is only there to help you out. But as a good clinician, I think even today, people of the older generation say that how in our time we were used to manage with the clinical acumen. But I say that at modern times, the people are better than the senior people. Ask me, I will give you an example. The people are using the USG for the blockade. You have already minimized the complications. You have increased the efficacy rather than going, I may say, out of 10 senior people, 2 or 3 may be doing good blocks with the precision because I think they have got that acumen, they've got that learning curve, they've learned so fast that they are giving good blocks blindly. But out of 10, only 2 may be there. But in present day scenario, out of 10, 8 will be doing a good blocks with ultrasound. So basically, we are replacing those things. We are concerned more with the patient safety than with the self-glory in the present modern era. That is more evidence-based rather than clinical-based or individual-based. So AI has its role, but in the postgraduate career, no. I think it should be no to them. After the post-graduation career, when you are responsible, you have got a degree, you have, the will to practice your specialty, you can go ahead with any type of intelligence you develop over the time. This is my take. I am not denying that fact. At a postgraduate career, I say no to them. Even Dr. Anjali will tomorrow. Somebody will answer all the answers in the answer sheet based on the AI. She will be giving a 0 marks to them. I think you will come to know that these are all AI oriented answer sheets.
Yeah, but my kids are using AI to write all their essays in school, so I don't know.
But that's why in essay contest also, in the national essay contest, which was held by ISA, we screened all the things where AI was used. We did not give them any, chance to come forward. They were given a negative marking also with the AI. I think, now, sorry, it's time to, felicitate our class people who have done a wonderful work. Is my screen visible?
Yes, sir.
Yeah, thank you. Dr. Anjali, again, thanks once again. Dr. Anjali is associate professor at VMC and Safdarjung, and she did a wonderful job in getting her team along with today to present such a wonderful class. Thank you, Dr. Anjali, for being today in the class.
Thank you, sir. Thank you so much.
And Dr. Kirti, she presented beautifully. So, Dr. Kirti, good thing. And I think you're still in the OT, wearing the OT
Yes,
dress and
sir.
getting the case done.
Yes.
Anyway, carry on your duties. So you are doing it in a real life, not artificially there.
Thank you, sir.
Priyanka, she also presented well. And that Krishika, so we had a discussion over the last only. Her idea, this style was very good. Slowly she was going and everything was being absorbed. So Krishika, thank you very much.
Yeah.
And Pavan, Pavani, she is the director of the Shankara Cancer Institute at Tejpur, Assam. I already told. Thank you, Pavani, for taking out time. And Anu also, she's assistant professor at Madurai Medical College, and she did, her specials. All these the senior people are presenting there as a screen coordinators, helping this class to flourish. And more importantly, I like to thank Dr. Madhuri and Dr. Ridhima both. They take special efforts to at least get the technical things, in a fine manner, so that the class goes in a very smooth manner without any hitches or glitches. So thank you very much to all of you. And I think it's almost 8:45. The time is, it's a good discussion actually, the 3 case scenario. It's a real crisis resource-based management. I think it was wonderfully justified.
Thank you, sir. And we have developed a curriculum for our postgraduates, and we do regularly conduct simulation-based sessions and other sessions also on crisis resource management topics for our postgraduates, as we have 65 postgraduates. So we do try to involve, along with the seminars, case discussions, we do take some simulation sessions to incorporate the non-technical skills part. Thank you so much again for the opportunity, and thank you to Dr. Madhuri, Dr. Ridhima, and rest of the team. They were very helpful with the trial run, and me and my whole team is very, very thankful to all of you to help us out with the flawless conduct of the program. Thank you, sir.
Thank you. Next week, we will meet with another interesting topic, anticoagulants and the regional anesthesia. That's a very, very interesting topic. Till then, I think it's time to say goodbye and good night. And we always end by saying, long live ISA.
Long live ISA.
Long live.